Assalamu alaikum wa rahmatullahi wa barakatuh. In this lecture, I will talk about the nerves of the lower limb. The main nerves of the lower limb are the femoral nerve and the sciatic nerve. They arise from the lumbar and lumbosacral plexuses. The lumbar plexus, this is the lumbar plexus, is the meeting and the branching of the nerves arising from the ventral roots of spinal nerves from lumbar 1 to lumbar 4. It provides supply to the upper thigh in addition to the perineum and lower abdominal wall. It lies within the psoas major muscle, and it gives off branches to the lower limb, includes the lateral femoral cutaneous nerve or the lateral cutaneous nerve of the thigh, the femoral nerve, the obturator nerve, plus the lumbosacral trunk. The lumbosacral plexus is formed by the union of the ventral nerve roots of the spinal nerves from the fourth lumbar to the third sacral, and it lies within the piriformis muscle anterior to the sacrum. Its branches include the sciatic nerve, the superior and inferior gluteal nerves, plus the perforating cutaneous nerve. Now, what are the course and distribution of the femoral and obturator nerves? As we said before, the femoral and obturator nerves arise from the lumbar plexus inside the psoas major muscle. The femoral nerve arises from the posterior divisions of the second, third, and fourth lumbar nerves, but the obturator nerve arises from the anterior division of the same nerves, second, third, and fourth lumbar nerves. The femoral nerve, this is the femoral nerve, passes between the iliacus and psoas major muscle, descends behind the inguinal ligament, exit the abdomen just lateral to the femoral vessels, appear for 4 centimeters only in the thigh before it divides into anterior and posterior division. This is the anterior division, appears darker in color, and this is the posterior division. The femoral nerve are distributed into the muscles of the anterior compartment of the thigh through the branch to the sartorius muscle that arises from the anterior division, and branches to the quadratus femoris muscle that arise from the posterior division. Also, it supplies the skin of the anterior and medial aspect of the thigh through the intermediate and medial cutaneous branches that arise from the anterior division, and the skin of the medial side of the knee, medial side of the leg and foot up to the distal joint of the first metatarsal through a long cutaneous nerve called the saphenous nerve that passes through the adductor canal. The obturator nerve exits the psoas major along its medial border. It passes along the lateral wall of the pelvis and enter the thigh after passing through the obturator foramen, and it supplies the muscles of the medial side of the thigh that is called the adductor muscles, except the adductor magnus, Also, it gives cutaneous branches to the medial side of the thigh. The sciatic nerve arises from the sacral plexus, from the fourth and fifth lumbar nerves, and first, second, and third sacral nerves. It is the largest branch of the sacral plexus, and it is the thickest nerve in the body. It leaves the pelvis through the greater sciatic notch, enters the gluteal region below the piriformis, descend to the back of the thigh, and about at the middle of the thigh it divides into medial popliteal or tibial nerve and lateral popliteal or common peroneal nerves. It innervates all the muscles of the back of the thigh that flex or bend the knee. Also, it innervates all the muscles that work the ankle and the foot. Plus the cutaneous innervation to a large area of the skin of the lower limb. Its branches arise from its medial side, except one branch to the short head of biceps, so any incision must be done along the lateral side of the sciatic nerve to save it. A typical site for an intramuscular injection is the gluteal region. The sciatic nerve passes through this region and needs to be avoided. The safest place to inject is the upper outer quadrant. The gluteal region can be divided into quadrant by two imaginary lines. We can position these lines using two palpable landmarks. The first landmark is the highest point of the iliac crest, and the second landmark is the ischial tuberosity. Now we draw a vertical line passes from the highest point of the iliac crest downwards, and another line passes horizontally through the first line and midway between the highest point of the iliac crest, and a plane passes through the ischial tuberosity. Injury of the sciatic nerve leads to motor and sensory effects. The motor effects include weak flexion of the knee because of paralysis of the muscles of the back of the thigh that flex or bend the knee, but the knee is still working weakly by the sartorius and the gracilis muscle. Also leads to steppage gait and foot drop due to paralysis of all muscles below the knee. The sensory effects include loss of sensation below the knee, except for the medial side of the leg and foot. These areas are supplied by the saphenous nerve. We can see here the nerve supply of the leg. This is the anterior, lateral, and posterior aspects of the leg and foot. As we said, the sciatic nerve is divided into the tibial and common peroneal nerves. The tibial nerve is responsible for the innervation of the posterior compartment of the leg and the sole of the foot. But the common peroneal nerve is responsible for the nerve supply of the lateral and anterior aspects of the leg and the dorsum of the foot. The tibial nerve supply all the muscles of the posterior compartment of the leg, all the intrinsic muscles of the sole of the foot, except for the first two dorsal interossei, which are innervated by the common peroneal nerve. The common peroneal nerve is divided into the superficial peroneal, this is the superficial peroneal nerve, and the deep peroneal, which is also called the anterior tibial, this is the anterior tibial nerve. The common peroneal nerve collectively supplies the muscles of the anterior and lateral compartments of the leg, one muscle on the dorsum of the leg called extensor digitorum brevis, the first two dorsal interossei muscles on the dorsum of the foot. One of the important clinical points regarding the injury of the common peroneal nerve. The causes mostly is due to fracture of the neck of the fibula or wound in the popliteal fossa. The motor effects include paralysis of the muscles of the anterior compartment of the leg, leading to foot drop, and also the muscles of the lateral compartment of the leg, which leads to inversion of the foot. The deformity is called foot drop with inversion. Foot drop with inversion. The sensory effects include loss of sensation along the distribution of the common peroneal nerve and its branches, the superficial and deep peroneal. The area affected is the anterolateral aspect of the leg and the dorsum of the foot. Thank you.